delighted to have Dr. Suzanne Crowe, President of the Medical Council, and a fantastic panel who we'll introduce afterwards for the presentation this morning. So this is our monthly IEHG, NDPT, UCD Grand Rounds, and should be a fascinating discussion afterwards. We encourage people to use the Q&A and the chat function throughout the meeting. So without further ado, I'll introduce you to Dr. Suzanne Crowe.
Good morning, everybody, and thanks for joining me this morning. As I was really delighted to get the invitation from Tomas. Tomas and I were in college together, and we've both travelled our own roads to get to the point where we are. Certainly, I don't think either of us would have predicted being on a webinar more than 30 years after graduating together. But so as Tomas said, my name's Suzanne Crowe, and I am current chair of the Medical Council. And I'm very grateful for you all joining us to discuss something that the vast majority of us try to avoid, which is exactly the reason why I got involved in this business, because I didn't like the fact that when the letter came in from the Medical Council or the email came from the council, that it was literally a case of terror in the heart. And I think it was largely because I didn't understand what regulation was about and what the council was about. And that really bothered me. So I decided a couple of years ago to get involved and find out more. And my intention was really to find out what goes on in regulation, what goes on in the council, and then spread that message to as many people as I could. So as I said, I went to college in Trinity. I then decided to do anaesthesia and completed my training through the college. I became gradually more and more interested in working with children. And so I completed my training by going to Melbourne to the Royal Children's Hospital. I now work in Crumlin. I've gone half-time since I took over this particular role. And I have some academic connections with both Trinity and UCD. When I look back at my own 30-odd years of working as a doctor, I think one of the things that is characteristic for most of us is that we don't tend to rest on our laurels or give ourselves a heck of a lot of praise. We tend to always be pushing on, looking for the next paper, the next job, the next exam, and then pushing on to other milestones. But I would encourage any of you who are in training at the moment that occasionally you take a moment to reflect on where you've come so far. You've already got into a very difficult course, got through it, and you're making your way through. And you've obviously encountered lots of other challenges in terms of working through a pandemic. The Medical Council is in the background all the time, and I think that that's something I didn't appreciate when I was in university, and then when I was doing my training with the College of Anaesthesiologists, is that the Medical Council already had a relationship, in fact, in the background. So it's not all just about the letter that comes in and strikes terror in the heart. The council works under a legal framework, and it goes back to the Medical Practitioners Act of 2007, which is a rather difficult piece of legislation to work with. And so there's been a few amendments since then, and we're still waiting for these last couple of regulations to be enacted. And I'll speak more of that in a moment. So the council is responsible for protecting the public in its interaction with doctors. And the way they do that is by producing standards and then inspecting and accrediting with those standards. There's 25 members on the council and 13 of them are non-medical. And again, I think there's a lot of misinformation around the non-medical members. I remember in 2007 when the legislation was introduced, there was a lot of fear around what a lay majority would mean in terms of decision making. But I have to say, working with these 13 non-medical members who have changed over the last 5 years, I'm always very impressed at the compassion, in fact, that they show doctors. And they're often very good at putting perhaps one error or a series of problems in the wider context of a career that's gone on for many years and all the many lives of patients that doctor has touched. And I think they're often kinder, actually, to doctors than sometimes we are to our own profession. So the mix is really important and introduces a lot of balance to decision making. The medical members span across lots of different specialities, and some of you might have noticed that we are currently running elections for new members at the moment. We meet quite a few times during the year for regular meetings. We have lots of committees and subcommittees, and we also have emergency meetings. They're run under a piece of legislation or a part of the Act called Section 60. And they are emergency meetings where we get together to discuss a case for a particular problem where it might be necessary to take a doctor immediately off the register. That's done through application to the High Court, and that's if there's a major concern with regard to patient safety. So in the background, what we're doing is accrediting education and training according to various standards. And there is a World Federation of Medical Education, and we work a lot with that body, and they produce standards which we then introduce or ask training bodies and undergrad medical schools to incorporate into their training. We have to also work with a lot of EU directives that can be quite tricky to work around, and that's due to the free passage of work across the EU. But that means, again, checking that doctors who are coming in who've trained in other countries meet the same standards of education and training as would be the case if you trained in this jurisdiction. So a lot of quiet work, I would say, or back office work that goes on. We also obviously maintain the register, which is in a sense a gateway to the profession in Ireland. And that's a very important role as well. And it's really, that's a live register. It literally changes every day. Every day we send information to the HSE on the doctors who are on the register, because doctors can come on and off the register for a whole variety of different reasons. Of course, the piece of work that gets all the attention is the investigation of complaints against medical doctors. And that comes out of, I'm going to talk you through that process now in a second, but it's for obvious reasons, it does tend to get a lot of attention. And there's a lot of fear within our profession and in other professions with their regulatory bodies. It's an uneasy relationship. And I think that's probably an understatement when I say that. So we monitor the programs of education, we inspect the clinical sites, and again, we have a lot of changes planned on that. And we also have a very close relationship with the postgrad training bodies. So as of February 14th, we have nearly 28,000 doctors on the medical register. That's the highest it's ever been. And there's still a preponderance of male doctors in our country. But if you look to the younger age range up until about the age of 35, 40, it's about 55% female. So there's no doubt that within the next 10 to 15 years, medicine is going to be predominantly delivered by females. And that has a lot of implications in terms of what we need to do with our training schemes and how we need to offer a range of different structures in consultant posts. Because many women and many men no longer want to work full-time, either in training or as consultants, and we need to move with that. A big part of the council's business and a lot of the education that we do is around professionalism. And again, that's woven into undergrad and postgrad training. This is just one definition of it. So it's the competent professional. But of course, the public expect so much more than that from us. And it's all about trust is really what it comes down to. So each one of you, when you leave this meeting today, will go about your day meeting patients, creating trust and maintaining trust. And it's like a little kind of a plant. It's an orchid, and it needs to be tended very carefully. As part of our legislation, we're asked to produce the ethical guide, and what it is it clarifies the standards of care that patients should expect. It's not a legal code, and I think that that's an important thing to say, But at the same time, it's probably the only document in the country that gathers the standards of care that patients would expect from their doctor together in one place. And for that reason, it's very often referred to when questions are raised about a doctor's clinical practice. We are currently reviewing it, and there will be a new edition available in the summer. But certainly what is available at the moment is on our website. And if any of you have never looked at it before and you have 5 or 10 minutes, I would encourage you to look at it. We're going to move to an app-based system in the next year or two, and the guide will be on the app. So hopefully it'll be more user-friendly. So as I said, professionalism is incorporated at all levels into medical training, and that's done under a mandate from the council to the various bodies. So I would have encountered it as a mandatory professional module during my own SPR training, and you and your different training schemes will encounter it. And then the HSE obviously runs different workshops on a whole variety of professionalism related topics like open disclosure. It is a responsibility of each doctor to interact with their regulatory body and to work to the highest standards that they can. We also do a lot of research around particular areas which we would be keen to lobby and propose legislation changes. So if you are asked to complete a medical council survey, I would ask you to do so, because getting your voice into those pieces is really one of the main ways that we can actually produce reports and try and lobby for change. We do know that we are actually still one of the most trusted professions in society. So we may get a lot of criticism from lots of other groups in society, but in fact, when it comes down to it, and when you go back out into your outpatient clinic today or into the day ward and you're admitting a patient, we very much see that the vast majority of our patients trust us to do the right thing. They also trust the fact that when I introduce myself and say, I'm Dr. Suzanne Crowe, I'm your anaesthetist for today, they, in that introduction and in the start of that relationship, they are taking for granted and they are trusting that I am trained to the highest standards and that I know what I'm going to do and how to do it. And I also know how to get myself into trouble, how to get myself out of trouble, and how to ask for help if there's a particular problem. So in fact, in every single time we touch a patient's life, there's an awful lot of non-verbal communication goes on. And I think we sometimes forget that, that's what a patient sees when we introduce ourselves as a doctor. I explain it to a lot of the medical students that I work with, that trust is a bit like a bowl of water that we carry around with us each day. It's absolutely full to the brim, and we're all the time trying to make sure that every interaction means we're not spilling any of the water. Unfortunately, that trust can be damaged, and that's where I suppose we end up seeing complaints coming in from complainants. And the vast majority of our complaints do come from members of the public. We receive relatively small number of complaints from hospital managers or HR departments, which is curious because quite often, Ireland being a small country, it's well known that there might be issues around a particular practitioner, a particular department, or a particular hospital. And so I think we have a lot to do in terms of the Medical Council's relationship with employers as well, to try and improve understanding, because the earlier that we can receive information, the more coaching and gentle encouragement can be done to improve things. When it boils up and there's an actual patient safety event and a patient is harmed, it's very late in the day to be trying to do things. And really what patients and what families want at that time becomes something very different. And you see an awful lot of anger, obviously. Almost 20% of complaints that we get in, when we get complaints in, they're all triaged into, I think it's 44 different categories of complaints, because we need to deal with the most serious complaints quickly. But I think it's somewhere between 17 and 20% of complaints that come in fall into the communication category. So that's very understandable, I suppose, if you think of almost 28,000 doctors on the register and the millions of interactions that take place, the conversations that take place each day in a variety of clinical settings. Many times English is not the patient's first language. Many times English is not the doctor's first language. And there can be lots of other cultural differences, but also we're working in a health service that's absolutely under siege at this stage. And so it's very difficult to devote sometimes the amount of time that it takes to have really effective communication, and then to circle back and check that your message has been understood and that you've had time to listen to the patient. So I think communication issues is a complicated issue. It's certainly not one that's easy to deal with. When a complaint comes in and there's interaction with a doctor, any of you who have received a letter of complaint, you will have noticed that the letter contains really legalistic language, because it obviously emanates from solicitors that are employed within the council. And so I'm really keen to work on that at the moment as well, because I think when it's from the perspective of a doctor, when a letter comes in that in any way threatens or mentions potential suspension from the register, it's a bit like when you mention a tumor to a patient, they leave the room thinking that they have cancer. And it's very much, in my mind, the same when a doctor gets an incredibly legalistic language. And so we have a lot to do to actually address that. And we are putting in place a couple of measures to support doctors to understand and to engage as much as possible, to get in touch with their indemnifier as soon as they get a letter, and to just remain connected, I guess, to the issue. Because if you do get a complaint against you, you will be stunned. It will go to the core of who you are, because being a doctor is very much part of our identity. So when you first read a letter like that, it feels like a direct attack on who you are as a person. And so you do need, I suppose, a period of reflection. You need some support from people who know what's going on. And if there's a particular issue, it could be related to performance. And it's really important at that point that a doctor can gain insight in order to get themselves back out of that performance issue. For example, as an anaesthetist, if I am doing central line insertion every day and my rate of pneumothorax is way in excess, perhaps, of some of my colleagues, if that's presented to me as a piece of information and potential patient harm, I need to understand what's behind that. I'm not going to be very happy to hear that perhaps I need to go and do some additional training, learn to get a bit better using ultrasound. But I have to gain insight into what the issue is, accept that there is a problem, accept the coaching, and try and move on from that. So insight into complaints is very important and is really the mechanism for getting doctors back on track. Because there's no doubt if you don't have insight, it's very difficult to progress after that. So one of the changes that's coming down the track in terms of complaints means that over the next couple of months, we are changing how we investigate complaints. So as I said, we triage complaints. So complaints that are less substantial and perhaps more vexatious in nature, the CEO with a small team of people will now have the legal powers to conduct an investigation and hopefully dispose of the complaint, if that's what's appropriate, as quickly as possible. The Preliminary Proceedings Committee will also sit in subcommittees. So that again should mean that complaints are investigated and disposed of as quickly as possible. The preliminary proceeding committees legally will now be able to accept a promise from a doctor to not engage in a particular course of action, or do a course in something, or do some more training, or not prescribe certain medications. So they can accept undertakings. And that again, hopefully will reduce the delays that go at the moment with a complaint against a doctor. Because as traumatic as it is for the complainant to be making a complaint, and traumatic for the doctor who involved in the complaints process, it's not helped by the fact that at the moment there are substantial delays in managing complaints. And so you can be under the stress of a complaint for many years. And that's the regulator creating harm in itself. And so I'd be very optimistic that these changes will make a difference in terms of what we can do to respect the complaint, respect the complainant, respect the doctor, and get the matter dealt with as quickly as possible. We have about 40 complaints that proceed to fitness to practice each year, and it's likely that a lot of those will remain the same, but hopefully we will reduce the number of vexatious and more trivial complaints. So just going back to communication, again, it's picked up in the ethical guide, and there's encouragement around, again, the protection of trust, but also just emphasizing that the communication is also very important between colleagues. And quite disappointingly, we see a fair number of complaints of doctors against doctors, often arising from personality clashes, arguments and conflicts that haven't been dealt with and limp on and end up coming in as a complaint to the council. We produce a couple of different guides that are meant to assist how doctors work within this environment that we're in. And we are also moving to a form of regulation which is known as right touch regulation. So at the moment, we are quite a heavy-handed regulator in terms of international practice. And in a sense, it's a very large hammer, sometimes to be hitting quite a small nail. If you think of the 300, 400 complaints that we get in each year, about 40 or 50 of those are very significant and need further action, but there's a large proportion of them are not. And so it's a case of moving to a form of regulation that allows us to focus on the really significant issues. We also need to develop a model of regulation where we can focus on an institution or a department as a whole. So at the moment, we don't have those kind of measures apart from inspection and accreditation of training environments. And so when we are aware of a hospital where perhaps there are an excess number of complaints coming out of it, or quite adverse patient safety related incidents, at the moment, our regulatory model is not designed to actually really pick up and deal with that. And nor is HICWA's really, to be fair, because HICWA can go in and inspect and they can produce a report with recommendations, but they don't actually have any legal powers in terms of creating change. And that's a bit of a failure, I think, in the regulatory environment. So hopefully moving to what's called a right touch regulation, which is where New Zealand and to a certain extent Canada have moved to, we will enhance our role in protecting patients, respect the complaint and the complainant, but also introduce a level of support for doctors. Just circling back to some of the research that we do, you might have heard some things about the Your Training Counts survey. That's questions that we ask trainees who are in the middle of medical training to give us information around the training environment that they're working in. And then we do another piece of research called the Medical Workforce Intelligence Report. And when we published it last year, what we did was we conducted a lot more analysis and tried to, instead of publishing just the figures, but also to try and take out the message as to what it was actually telling us. And that produced a lot more focused report, and I think was probably noted across the health service in being, I suppose, a little bit stronger in terms of what we were saying and speaking to the really difficult environment the doctors are working in at the moment. Many doctors are still working well in excess of acceptable working hours. I include myself very much in that, and the vast majority of consultants still work well in excess of 48 hours each week. And it's probably one of the reasons why many people are keen to do less than full-time working, because less than full-time working for the vast majority of doctors would probably just be a normal working week for everyone else. We have too many people not in training roles and or on the general division. So when the general division was first developed, I suppose, by the council, the idea was that it would be like a transitory kind of division that people would pass through for a fairly short period of time if they hadn't moved from an intern post or they just come into the country, and whilst they were waiting to go on to some kind of a training program or into a training role. But has become, there's almost 7,000 doctors in this country now on the general division, and many of them are completely adrift in terms of supports that they could be getting from postgraduate training bodies. They're also adrift in terms of career progression and training opportunities. So this is a real failure within the system, and it needs urgent address. And we're putting together a paper at the moment to bring to the Department of Health with a number of measures to try and deal with this because it's not working out well for us. We also take note of doctors who voluntarily withdraw from the register. And many of these doctors are graduates of Irish medical schools. A disappointing number have left the specialist division. So if you think that these are doctors who have already got a training post and perhaps they're several years into their training, but for a variety of different reasons have decided to leave. So almost 1,000 doctors withdrawing from the register is a lot, particularly when you think of the fact that many doctors, like myself, when I went to Australia to do my fellowship, I didn't withdraw from the register. That would have been too much of a hassle to have to try and come back on then. So a lot of doctors who are away doing fellowships for a period of a couple of years stay on the register. So if you make a decision to leave the register, I think that, again, that's quite a monumental decision. It's something that you wouldn't have done lightly. And I think understanding the reasons why doctors have decided to do that is really important. Very disappointingly, a lot of doctors cite family reasons for leaving the register, which again is going to need more attention. Burnout and the very difficult healthcare environment that we find ourselves in are huge contributors to this. Also, excess working hours, lack of career progression, and reliance on international medical graduates. So in that almost 1,000 doctors, you find a substantial number of doctors who graduated, got their basic medical degree in another country, came to Ireland for training opportunities, were not afforded those training opportunities, spent a number of years here on the general register working in what I suppose most of us would call service posts, and then take the decision to leave the register and go to other countries where they are given better training opportunities. This is a real loss to our system. And a lot of these doctors didn't want to leave. They actually wanted to settle in Ireland with their families. So again, understanding the reasons why doctors leave the register is important in terms of lobbying for change and lobbying for improvements. These all impact on patient safety. There's no doubt, and sometimes we have to explain this a little bit to the Department of Health, who I guess would like to remind the council of their primary role in protecting the patient. But we can't protect the patient and we can't deliver patient care if we don't have enough doctors, and if doctors are not trained to the best possible level. And the well-being of doctors is another central theme. If we have too few doctors and everybody is working absolutely bananas hours, then doctor well-being becomes a threat to patient safety. And the council did run a campaign on this last year or the year before. I really can't emphasize enough the need for every medical student, trainee and doctor to have their own GP. It really, it is a source of complaint to the council. Doctors can find themselves in a bit of a hole where they start prescribing medications from the darker side of life for themselves, and it's not good care. You can't be objective about your own mental and physical health. There are some supports on our website as well, and there is a charitable organisation called the Practitioner Matters health program, which is run by a lovely GP called Ida Delargy, who's based in Blackrock, with a number of other doctors, and they offer confidential medical support to medical students, doctors, dentists, and pharmacists. So the Council also has a health committee, and if a complaint comes in that appears to be related to a health issue with the doctor is asked to engage with the health committee with the aim of trying to support the doctor to get well and to come back into active clinical practice. For example, if living a stressful life, working as an anaesthetist, managing family and all that kind of thing, I start to self-prescribe perhaps benzodiazepines and opiates and perhaps drinking alcohol to excess, and I find myself in a patient safety or a patient incident that arises and then there generates a complaint, I will then be encouraged to work with the health committee within the council, address and get the help I need to get out of my substance issues and my psychological issues, and come back to work and, you know, contribute to patient care again in the future. So there's a huge emphasis in trying to get doctors back into work. Boundaries is another thing. Even though we create very close relationships with our patients and we create trust with patients, we can't blur those boundaries, and that's really important. Also, I suppose I did touch on this a little bit at the start. Medicine is a very competitive profession, and we're all often chasing the same goal for many years, but it's important to remember that we have to also lean on each other and take care of each other as well. And I think that's really important. And certainly over the years, in the many different difficult scenarios that I've encountered, it's peer support that has made the biggest difference to me, because the best support to you is from somebody who understands what you've been going through, especially if it's related to a patient. So that's all I have to say on the Medical Council at the moment. And I'm very happy to take questions and also to interact, obviously, with our marvelous guests on the panel. Thank you.
Thank you very much, Suzanne. We've got an excellent panel this morning, so I might just start by introducing some of them. So we have Dr. Clive Kilgallen, consultant histopathologist in Beaumont Hospital and president of the IMO since 2022. Prof. Gabrielle Colleran, who's vice president of the IHCA, consultant pediatric radiologist and head of radiology at the National Maternity Hospital.
Ruth Shipsey, who's CEO of Medisec Ireland and a Waterford woman. Very welcome, Ruth. And we have Stephen McMahon, who's CEO of the Irish Patients Association on. I thought we might open the discussion off, and I was maybe go to Stephen to start with, just at any. I mean, Suzanne has a great presentation, has given a very nice perspective of things, but I'd be interested to know the patient's perspective, particularly with regard to making complaints to docs to Medical Council. I mean, is that a stressful scenario for patients? Are there any other observations, Stephen, you may want to make, or just comments following Suzanne's talk?
It is. Good morning. I hope you can hear me there. I'm actually on a break here in Amsterdam, and the communications, believe it or not, are not the best. A small correction. I'm actually just a non-executive director of the IPA. Our funding was withdrawn in 2013 by the HSE. So we're working wholly on a voluntary basis, more or less, for the last, I don't know how many years. But the important thing is that we still manage to engage with about 300 to 350 patients per year to help them with their process of engagement. And first of all, I'd like to also thank Suzanne, that I think that was a really helpful presentation, because it does really identify areas that we have so much in common. You know, like I've often said to some doctors when I've come across them, they've been a bit poorly themselves, you know, once you're a patient, you're an ARTURF, and, you know, we want to see them treated in the same way as any non-professional doctor, you know, that we would expect for an ordinary patient, without any discrimination as to who they're from or whatever. The journey of making a complaint with the council can be very arduous. The patient and their family are not used to the legalese sometimes of the letters that are sent, and they really feel at times too that it's the system, you know, like that it's the doctors regulator as opposed to in their interest, and to ensure that their interests are represented and fairly reviewed and so on. And I mean, if we only look at, you know, you might think that it's the patient that didn't find an outcome against a doctor that would be the one that's really can be upset. We've only just seen in recent days, I got a press statement, I think it was from RTE, about a recent case that you had, that the patient's family were deeply upset that the hearing wasn't in public. So you can see that it's not just where somebody hasn't found or don't really understand the nuances of a decision. And sometimes that's what we actually do, will help them sort of understand what that decision has been about. But just one or two very quick points. I think it's really, you can't underline enough the importance of trust. It's a very fragile domain between stakeholders and between the system and patients. And you know, as I say, it's very difficult to restore once it's broken. I think that one project we've just almost completed now, which is we have looked at the ethical guide, and we've sort of automated it so that we have sort of keywords that patients would use to identify the various codes that have been that there's a question mark, and that should make things easier to, you know, for evaluation and so on going forward. Again, the numbers have been said there are quite low, but I think also we have to look at the fact that some of the studies, INUS from both INUS 1 and INUS 2 from the College of Surgeons shows that I think about 1 in 8 admissions to hospitals has an error, and I think 70% of those are preventable. So, you know, that would say that there's a far bigger instance of issues that need to be fully investigated and so on. And I'm not convinced that that is actually happening. And as Suzanne, Dr. Crowe mentioned there, you know, that you don't have a say in the reform process. And I think that there's no better bodies to be involved, you know, from the point of view of trust in that reform process, because again, it's so important for colleagues, if they do see someone that is underperforming, to raise the issue within whatever structures are there, with the goal of actually protecting the patient and protecting their colleagues. And, you know, we have come across situations, certainly one case that I can remember, and I'll finish on this, was a case that a foreign doctor had got a job as a senior registrar in a hospital. And was, you know, there was a famous quotes in the paper that the individual, I think, couldn't even take someone's pulse. Now, the person was actually sanctioned and I think removed from the register. And when we were in touch with the GMC in the UK, they wrote to us, I think about 6 months later, to say, actually, we're dealing with an investigation into that particular doctor, and invited us to attend the hearing. But the important thing was, their finding was that it was about the doctor, I think, hadn't disclosed to them about what had happened in Ireland, but they had put a little caveat in their decision to say they felt that the Irish regulator had been a little bit too tough on the individual, that there was an accountability aspect by the employer to ensure that the person had the competence to do the job that they were actually filling. And I think that I'll leave it there from the point of view that, and we've been advocating it for a very long time, that senior management in the system do not have any similar regulatory process to be held to account for when they actually make bad decisions that impact on doctors and nurses and other professions, and indeed, obviously, patients. And thank you for the opportunity to contribute to this meeting this morning. It's very helpful.
Thanks, Stephen. We're going to come back to you on that. I'm just going to open this up to the panel, but also I'd encourage any questions from the audience. Please bang it into the old chat box. We do have one from Dr. Catherine McGarry that I think might be helpful. It might be able to bring Ruth and Suzanne into this one, if that's possible, and other comments. Is there any scope to include legal support for medical counsel interactions under the CIS scheme? One source of stress is the need for practitioners to have their own private indemnity, whether they're public or private, to cover for possible medical counsel complaints, amongst other things. Any comments on that? Maybe either Ruth, Suzanne, thoughts on that?
Do you want to go first, Ruth?
Okay. I think this came back to when the state indemnity was coming in back, I think whatever, in around 2000. And I think doctors wanted to have their own representation. And one of the big concerns when we went to the CIS scheme was that doctors wouldn't have the voice. It would be the hospital or the entity as such. So I think at that time, I remember the conversation around doctors was that if they were complained, it was personal to them, and that they wanted to have, you know, cover themselves so that they knew that it wasn't the hospital or anyone else's interest. So that's my understanding going back. And I think supplementary cover in relation to that, if I was a doctor, I'd want to feel that I had my own team on my side. So I think that's where it comes back to. So I don't know, Suzanne, have you?
I'm not sure how it grew. I think for the way forward, in a sense, is to have a legal support between the doctor and the council to help understand the very legalistic language that's used in the letters, which has its own role, and obviously there's an important legal message when there is a complaint. So we are appointing a liaison person who, as soon as you get a complaint that's significant, you will be encouraged to engage with, who will talk you through the process, encourage you to contact your indemnifier ASAP, and get all the help that you need, rather than, you know, just deleting the email or putting the letter in the whole table drawer and hoping that it goes away. So this person won't be part of the complaints process, but they will understand all the legal steps, and will be able to walk the doctor through it. And we are appointing a separate person to do the same with complainants, because there's no doubt that we're just not getting our own communication right in terms of us communicating with doctors in a very stressful situation, and us communicating with patients in an equally stressful situation. So there's lots of improvements could be made, but at the end of the day, every doctor needs indemnity. It's part of working as a professional. You're not covered by the clinical state indemnity scheme for interactions with your regulator or with the coroner's court. They will, when the CIS legal support come to the coroner's court, they're there really principally to protect the interests of the hospital. I don't know, Ruth, maybe I shouldn't say that, but
yeah, and that's going back to where it was coming, Suzanne. That's why people wanted their own in relation to it, so that they knew that they have, and people who are used to dealing with the medical council.
Yeah, so I think we need to definitely go back to the days where on commencement of work as an intern, you take out your indemnity with whatever company you fancy, and you stick with your indemnity throughout your training and throughout your clinical life.
Thanks. I just commenting personally, I've certainly been through both Coroner's Court and Medical Council, so I would recommend your own. I think it's important about indemnity. I think it's a challenge. Some of the people in the younger won't remember the MDU was in Ireland, but they bailed out and then had a monopoly of the MPS. I'm not putting a plug into this, although you can pay me later, Ruth. Medisec obviously is very welcome in the market, and they have a relationship with MedPro. So there's a new competitor on the market, and I'll say no more than that, but I think that is very welcome, because the monopoly was not a healthy thing. We have a second question. I might hand over to Tomas.
For those that are traveling abroad for fellowship, is there a possibility of a discounted rate for annual retention, considering they will not be practicing in Ireland and will be paying fees in another jurisdiction? This could also apply to people moving to Australia post-intern year who plan to return.
Yeah, it's an excellent question. We started this year by reducing fees for those who taken time off to look after their newborn. The next group of people that we're hoping to address will be people on long-term sick leave, carers leave, and adoptive leave. But the other, I mean, that's a very good group that question mentions, is those who are working outside the country. And then the other group are doctors who are retired, but for their own reasons would like to stay on the register. And so we will introduce these gradually over the next couple of years. What we're trying to do is introduce it without increasing the fee for doctors overall, because it's already a hefty fee, and it comes at not a great time of the year when you often have to pay for lots of other bits and pieces. But the council has significant financial reserves, and so my role, I suppose, is to speak for the profession and to try and encourage a balance between having financial reserves and also using your reserves to actually give doctors a break when it's appropriate in terms of fees. So there you will see more about this.
Thank you, Suzanne. Just a comment from Alison Bone: having managed clinical incidents in an acute setting, cannot overemphasize the significance of investigating the system as a whole, including human factors, to facilitate a thorough investigation and support for both patient and the staff. So yes, very good point, Alison. And when I hear Stephen talking about errors in the system, we working in emergency medicine, we have kind of an international acceptance now that overcrowding causes harm to patients, and that's well documented. And it's one thing investigating an individual in an error, but it's another thing, we have to call out the system as it is, in terms of where it facilitates or leads to error happening in the system. And it kind of opens discussion. I know you mentioned about open disclosure, but I see now the HSE are starting to talk about just culture and have a page on their website. It's an important discussion that needs to be had, but I think it's going to be very challenging in our current system.
We might open that up to the panel. Any other comments? I mean, Clive and Gabrielle, I think that's a good point. One of the things that I thought was helpful with regard to clustering hospitals and groups, if I use that term, is that, and I'd be interested in Stephen's thoughts on this too, that I certainly have a sense in the last 4 to 5 years there's been an uplift in quality, particularly at level 4 hospitals, I could use that term, availing perhaps of some links to the major hospitals, and then building a learning culture, which is really what our role is, and my role, Tomas's role is in our system, is key. But that part of that adjust culture will be important, so that it doesn't achieve much when you take an individual doctor to the court and you get financial gain, frankly. It doesn't change the system. Whereas if you have a system approach, okay, what went wrong? Why was this doctor not up to par? Why was a mistake made? Was the person overworked? Was enough resources, et cetera, would be very helpful. And we need to think about how to move to that area. And that makes open transparency much easier and much more effective. But the problem is we've had policy change after policy change from healthcare, and we're going through another one at the moment. And the others, you have a few years at something, it never gets finished, it gets half-baked. So I'll bring some of the other panel in. Any comments, Clive? You're on mute. Any thoughts?
Yeah, I just think there's the environment that we work is just so difficult. There's just so few of us at all levels. The resources aren't in the hospitals. For clinicians, getting even the simplest thing like a CT scan or a patient admitted to the ward from the outpatients is like a life event. That there's a disconnect, I think, between people on the ground and, again, kind of sometimes, well, in hospital management, and I know that hospital management, some places are working very hard in their own confines, and they have their own kind of difficulties and often are kind of budgetary restrained, and many hospital managers I know work really, really difficult. But the point made is that hospital managers are kind of senior professionals too, and they need to be accountable too. I think that's a very important thing. Another issue that I would like to, a very important thing, is about the culture that we have in medicine, that we really do need to look after each other much more as doctors, and certainly something I stress that to our medical patients. And we know also from the IMO surveys that we've done, there's a bullying going on, there's a lot of kind of poor behavior going on, and all that has to stop. And we need to have that all people, clinicians, all doctors, from student to senior doctors, feel equally valued on the wards and equally treated with respect. And that happens with all of us right now, right today. It's something that's another big piece of work that needs to happen.
Thanks, Clive. I just make a comment that we had a very excellent wellness session in our last IEHG grand round, which I thought was really excellent, and it was nicely pointed out. Yes, we do have to look after our own wellness and make sure that we have our time and break and indeed support from colleagues, but the organizational system has a big responsibility here as well, and that came through loud and clear with our discussion and presentation a month back, that that needs to be considered. So I often ask the question, and I was on the matter board for a while, and it's like a broken record. We have 2,500 employees. Why don't we have a gym? And that's a very good question that you've got, it's something like Google, that there should be something for staff actually to have a bit of exercise break, shower, and rejuvenate themselves and go back to work. So I think that's important. Gabrielle, we might come to you. Any thoughts?
So I take it further, Tim, and I'd say, not only why don't we have a gym, but why don't we have a creche on site?
Why don't we have what site?
Creche.
Why don't we have a creche on site? We have, if I look at the next generation of consultants, within the next 10 years, they'll be 80% female. Many of them will be women of childbearing age. Many of them will be parents. And having that access to childcare, especially the antisocial childcare for those late shifts, the government is very keen for extended working days as well as the on-call that we already provide. And part of supporting people to do that is providing the services. Where I did my fellowship in Boston, I dropped my toddler into daycare at 6:30 and I was at my desk at 7:15. I was able to do that because my daycare was on site in the hospital. So I think listening to Suzanne, I'm really enthused about the changes that the Medical Council are making. And I think it really does come back to that if the system is resilient, the people can be human. And if we look after doctors well, and we make sure they're getting enough rest, that their workloads are manageable, that their call rosters are manageable, that they're getting the training, that they're having the time for work-life balance, the patient care aspects work out, because happy, rested doctors who are getting to perform at the level that they've trained for, that have access to the resources they need to do their jobs, so that they know that patients don't come to harm because of delays or because of lack of access. Those are doctors who have the best chance of having good well-being in themselves, and that supports them then to give the highest quality of care. Within the IEHG, as many of you will know, last year we published a paper. We did a survey of our members on burnout. Now, we know that burnout across doctors across the world is very high. It's 30% worldwide, but in Ireland it's nearly 80%, and that was pre-pandemic, so it's only going to be worse now. So that's really worrying, because we know when people are burnt out, that impacts on their ability to deliver high quality care. It impacts on the amount of mistakes that are made. So I think Suzanne's points are really well made about how we have to mind ourselves and we have to mind each other, and we need that culture shift. And it does come back to, we need tort reform, and we need change the medical legal system, because we have to be able to learn from our mistakes in an environment that isn't punitive and threatening, because we know no doctor goes to work, well, nearly no doctor would go to work intending to harm a patient. And when it happens, we have that second victim of the doctor themselves. But our medical legal system currently is not set up to allow people to learn without that punitive aspect. That's not safe for patients, it's not good for patients, and it's really only the legal profession that are benefiting financially from it. Patients are suffering and doctors are suffering. And I think what I would love to see is patient groups and doctors coming together to advocate for change, for a system that would support learning so that everybody can improve from it. And so that when there is harm done and patients experience ongoing harm from it, that they can get looked after financially, get the medical care they need, and not have their trust damaged twice. We've seen recent cases in the news just in the last 2 weeks where people suffered serious harm, and then how they were handled by the system further increased that harm. And we can't stop mistakes. We will always have to deal with a certain level of mistakes, but we can change how we handle them and how we support people, especially the patients and their families, through it. So I'll stop talking now, because this is a topic I'm very passionate about, and I could keep going.
Thank you. There's a comment: on-site creche should be seriously considered for all doctors. I agree. I might just mention, sometimes us men drop kids off to the creche as well and pick them up too. So couldn't resist that one.
That's why I said parents, Tim.
Okay,
just make
others. Stephen, you want to comment?
Yeah, just one very quick point. I mean, I think everything that's been said, is really encouraging, but it does come down to the fact that we need a culture within the system that's safety focused, in a way that it's not, that everything we do, we try to do in a safe way, and encourage that and support that in the various initiatives that can happen. But I would like to make a quick point that I've come across, where people sometimes think that, that the litigation is all about the money. I have met quite a number of patients and their families, specifically families where there's been a death, that no amount of money can cover the grief that they carry for years. And, there has been a couple of times in the media, people saying, mentioning the money aspect. And I can honestly say to you, and I'm sure maybe many of you yourselves have come across, litigants and so on, that many years later, that they still have that pain and that hole in their life. And the one thing that they all really cry out for is that whatever lessons that can be learned from their experience will reform the system and make it safer for future patients, and hopefully a better place for doctors and other professionals to work in.
Thanks, Steve. That's actually what my point was made, that I think that the adversarial system we have at the present doesn't achieve that. And my point really was that we need a just culture approach to this, that have a look at the system, what went wrong with the system rather than individual, so that the individual is not put up in front of the stand and it doesn't achieve much for the individual, nor indeed for the parents of the child or the person where it was damaged. So it's exactly the same point I'm making, and we need a change or a different process to achieve that. It doesn't work at present. I'm just going to further question. I might ask this one actually of Suzanne. Just one of the thoughts I have is that actually I'd welcome Stephen's comment. And I think we're very good. Actually, Irish healthcare is very good. I think it's underestimated. I think we get a bad press in the media, and that's a separate topic we might discuss. How do we address that? But I think we have something we could market. Potentially, we could be training international graduates in a more formal fashion, rather than actually losing our juniors to Australia and then in an ad hoc fashion coming back. Could we set up rotations abroad, get the international training like Gabrielle got in Harvard, and come back bringing those skills back to Ireland, but do it formally? But some of the challenges that is actually difficult for some of the international graduates to get medical council rubber stamp, that's the word I'm looking for, it's not the correct word, but that process can be quite slow. And we have got to think about this, that we get a formal links in Australia, England, for Europe, America, etc. for training. Our graduates go abroad, theirs come over to us, and they learn how to do medicine, a proper history, physical examination, diagnosis, rather than over-reliant on investigations. So we do have a product that we could sell, but we would need an easier way of doing it. Is there any discussion in the Medical Council of that, or any thoughts about that, Suzanne?
Well, I mean, I guess I have to be straight up about the delays. We have had a lot of delays within the council, and that was due to a strange situation where we had the reserves, but we didn't actually recruit and develop the departments necessary to actually support the rapid registration of doctors. I think you'll never be able to get away from the situation where we have to check the credentials of doctors who come from a variety of different countries, particularly those that we don't have established training links with, and that's particularly non-EU doctors is the issue. And rather unhappily, the UK fell into that category in the last couple of years, which has really compounded the issues. So I think we can definitely speed up the process. We can develop the relationships. I think the postgraduate training bodies have a really important part to play in that. It's going to be a tripartite movement, really. The regulator will be one aspect, but the training bodies need to step up and help develop the training programs that will support the passage in and out of international graduates, because otherwise they run the risk that they'll be adrift in the system without the opportunities that they need, and they'll just leave disillusioned. So that piece needs to be completed. But I don't think we'll ever get to a point where registration will happen in a matter of a couple of days or a couple of weeks. I think it'll still always require a couple of months. And so I think people do need to get in touch as soon as possible if they're thinking of moving jurisdiction. When I went to Australia, it took about 9 months to set up my own visa and fellowship. I think anybody moving to Canada has had a similar experience, but it's about setting it up as soon as possible and making a move on that. But there's definitely improvements could be made on the council side. I would take that as very fair.
Okay, thank you. Any other thoughts just in relation to my comment about media? I was amused by it in some fashion, and maybe Stephen commented too, that certainly in the pandemic, doctors, nurses, allied healthcare professionals with the bee's knees and wonderful. And then the pandemic, it hasn't gone away, mind you, but it's sort of drifted more into the media background. And then there's a change afoot again. So there's often ongoing comments about poor healthcare in Ireland. I think that's sometimes unfair, and I think it's not balanced, and it seems a difficult interaction. And I'm just wondering if any panelists have any thoughts about that. How do we get that right? Because it doesn't seem that we've got that relationship with the media in Ireland correct, President. Stephen.
Yeah, just a very quick question. I mean, and it's a really, really good question. I mean, basically, we have in Ireland of two halves. One half on the acute side can get access to healthcare fairly efficiently and fairly robustly, if you know what I mean, and that would be people with private health insurance. And the other half of the population, then approximately, are on depending on the public system. And I think it was the famous hashtag Care Can't Wait. I mean, I have currently a patient who has been waiting to get his treatment for prostate cancer, where he was diagnosed in February of last year, and arranged a program, I think in July or August. And I contacted a well-known Irish advocate in the area of prostate cancer, and he said to me, ask the man, has he had a PSA test? And I said that to the man's wife about 3 weeks ago, and she said, actually, nobody had a PSA test. And she phoned me there last week to say he had it done and it had deteriorated more. So, it's this issue of once you get into the system, you can't, it is good. But the problem is getting the access, and that requires a number of steps. I mean, Sláinte Care is fine, but it's down the road. What can we do today? We can certainly try and maximize any resources that are there, expand ours as possible, but it's controlled because of the very things you've been saying here today about doctors working too long hours and so on. But, we really need to try and improve the access, whether that is having, I don't know, special clinics and flexibility to go to different hospitals and a number of different things. But that is the problem. It's the access. Almost 1 million people, give or take some. There's another person that was on to me just this week with a serious psychiatric condition, and the hospital, the local acute hospital, tell the family, sorry, we can't take him in because he'd be a risk to himself and others. And so therefore the family are coping with that in the community with maybe one visit a week from the psychiatric community nurse. So these are the real encounters of the public, and this is why when it does get into the media, an awful lot of people can relate to that, and that is the challenge.
Okay, so we're just going to tighten time. Gabrielle, hand up. What's your thoughts?
Thanks, Tim. So I think that this is a tricky issue, and I think it's a tricky issue for us as doctors to be really honest about. So if we look at patient satisfaction ratings, we do very well in Ireland when people get into the system, like Stephen says, I think 84% at the last one, which is very high internationally. And access is a huge issue. And when I started working with the IEHG, I really felt access is the issue, but once people get in, the care is really good. But take this in the spirit it's offered, Tim, you're not the average doctor. And so if you think that every patient gets the standard of care that you give your patients, you are overestimating the standard of care. And I have 3 children, and one of my children has chronic healthcare needs. And what I've learned from being a parent in that setting is that children and patients with chronic needs, it is very difficult for them to be honest with their caregivers about the mistakes and the issues, because they are dependent on those same caregivers for access and for ongoing care. And I myself have been in situations where I've been saying, oh, thank you so much, and everything was great, when things weren't great, because I didn't want to offend the caregiver and have them get the hump and have my child experience negative consequences as a result of it. But the problem with that, and I know many other parents who do the same thing, is that for us as caregivers, we can think that patients are having a better experience than what they are. And particularly patients with chronic ongoing healthcare needs, I think we have a long way to go in Ireland. And I have been shocked at some of the experiences that close family members have had in Irish hospitals in recent months and years, where some of the care has actually been quite sloppy, poor standard, communication, really disinterested care. And some of that for sure is overwork and caseload and burnout. But I think that can be hard for us to accept that happens, because we really like to think that we're all doing our absolute best every day. But sometimes that best can actually be very far short of the mark. And I think the more we have the patient voices in ways where patients can be honest without that fear that it's going to impact on their ongoing care. And that's a really tricky thing for us in a country as small as ours.
Thanks, Gabrielle. It's great to have that experience as both a service provider and service user. Clive, I think, has got his hand up also.
Yeah, again, just in terms of kind of patient access, it's very difficult for patients to sometimes get access, and they're facing into a kind of a long waiting time to even to get seen. On the other side, one of the things that my doctors who I chat to keep telling me about how absolutely stressful it is to be a doctor in a consultant and have a really long waiting list that there are patients waiting a year to see you. That's a really, really stressful thing for patients. And I know one doctor that I know left his public service and moved to the private service because the waiting lists were too long and it just got too stressful. He had no control over it. So that's just it works both ways. It's very stressful.
Thank you, Clive. There's a lot to be done to improve the system. Obviously, I think that's a consistent message, and patient safety is where we need to focus. And our next grand rounds actually will address that issue. So I'd just like to say thank you very much to Suzanne for the presentation this morning and discussion, and thank you very much to all our panelists and to everybody who's dialed in for another excellent discussion. And
thank you all. That was super. Thanks, Suzanne.
Thanks very much, everybody. Take care. Have a nice day.
You too. Bye-bye.